Now recording. I just want to make sure everybody's aware. So welcome everyone to today's CME CE Grand Rounds on fundamentals of providing inclusive care to transgender and gender diverse patients by Dr. Christian Creedle. I am Dr. Nicole Waldron. I am the chair of the CE-CME committee, and I'm just going to give you some information about the CME CE event. This event is 3 hours long, so it's good for 3 CME and 3 CE credits. There is a flyer that I sent out to everyone, and on there is a link to the SurveyMonkey. In order to get your credits, you would need to submit your survey by May 18th. So make sure that you get this done before then. I do have a disclosure to make. Well, actually, we don't have anything to disclose, but this is the disclosure. So when you're doing your survey, please make sure to indicate that we did make this disclosure. And this is it. None of the planners or presenters for this educational activity have relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. So please just make sure that you take care of that survey. I will open it at the end of today's training, and then it will stay open for the time period that is required by May 18th. All right, so now I'm going to introduce our speaker, Dr. Christian Creedle. He is the lead Mosaic psychologist, supervising psychologist at AIDS Care Group, a nonprofit organization that provides medical care, dental care, and social services to underserved populations in the Philadelphia metropolitan area. He serves as lead psychologist in ACG's Gender and Sexuality Clinic called Mosaic Medical Center for Lesbian, Gay, Bisexual, Transgender, Queer Plus Health and Wellness. At Mosaic Medical Center, he supervises all staff therapists and students in its training program. In addition to providing individual therapy in the HIV and LGBTQ+ programs, Dr. Creedle co-facilitates the Gay Men's Psychotherapy Group, facilitates the People of Transgender and Gender Nonconforming Experience Psychotherapy Group, serves as the Institute for Public Health Psychology's Chair of Diversity and Inclusion, and is a member of the ACG Diversity, Equity, and Inclusion Committee. He also supervises psychotherapy in ACG's Medication for Opioid Use Disorder Addiction Clinic called the Center for Integrative Medicine. Dr. Creedle specializes in working with people who are members of the LGBTQ+ community, individuals living with HIV, clients in recovery, and people with persistent and characterological disorders. Dr. Creedle uses schema therapy, relational cultural therapy, acceptance and commitment therapy, relational psychodynamic therapy, harm reduction, motivational interviewing, trauma-informed interventions, and therapy integration in his clinical work. Dr. Creedle is a graduate from the Chicago School of Professional Psychology, DC, and has built a specialty in cultural humility training for providers working in healthcare settings. So please help me welcome Dr. Creedle. This will be an interactive event, so you can keep your cameras on and your mics open. Just if you have noise in the background, please silence your mic at that time. Thank you, and welcome, Dr. Creedle.
Thank you very much, Dr. Waldron. Well, thank you everybody for being here today. First, I want to apologize for the camera issue not happening. You can't really see me right now. I like for these presentations to be interactive and being able to see my faces. I think one of the parts of that, but we're going to just do the best we can for today. So yeah, please call me Christian. But I am going to be presenting to you today on the fundamentals of providing inclusive care to transgender and gender diverse patients. All right. Again, yes, that was a lengthy introduction. I probably shouldn't have written so much, but that kind of describes what I do. My pronouns are he, him. I'm a gay, cisgender Black man, assigned male at birth. And I think it's just important for me to recognize that I'm going to be speaking, I'm not going to be speaking from my lived experience as I present on working with transgender and gender diverse individuals. So if there's something comes up, if you want to speak to your own experience, speak to experience that you have with your clients, I am not the expert on anyone's lived experience, and I'm going to be commenting on sort of like the clinical literature on the best ways to provide inclusive environments. But if you have some information that might be helpful to share, please do so. I want to empower you to do that. I think that'll be helpful for our presentation today. Let's see. So the objectives for today, we're going to be learning some terminology, getting on the same page about gender diversity, and working with trans individuals, so that the terms that come up that are important to be able to have a broader discussion. We're going to be understanding a little bit about the clinical concerns that this client population might experience. We're going to be building some skills that are necessary to providing gender affirming healthcare to trans and gender diverse individuals. And finally, we're going to be talking about how we can use our, become aware of our biases that inevitably kind of come up when working with gender identity. Okay. So what's the vibe for today? I want it to be relaxed, informal. Please feel free to ask me any questions that come up. I would much rather hear from someone if they had a difficult time using a term or understanding something, clarifying something, working through how to speak to somebody's experience than just talking the whole time. So please, if you have a question, feel free to ask. Again, as I was saying before, you're experts in your lived experiences. You all have genders. You all have emotional reactions and worldviews that are going to be important to sift through when working with people that are have a diverse gender experience. So I would like you to bring that to this meeting as well. We can all learn from each other, and I encourage people to be courageous. If you've ever, did a whoops or something like that with a patient and had a moment that was that needs some work, please feel free to bring that to this meeting. I'd love to talk through it and advise in any way that I can. And also, we're just going to learn sort of like a framework for the future, and hopefully this gives you some insights into where to go to continue your education in working with gender diversity. Okay. So some of the goals for today, if anybody's familiar with Sue and Sue, multicultural counseling, this presentation will be structured in a similar way. The expectation in working with people, working across difference, is that developing your knowledge of a specific clinical population or a specific group of people is important. Having an understanding of the terminology that's relevant. For speaking specifically with gender diversity, what gender affirming care looks like, understanding what to expect across a diverse range of gender expressions. We'll talk about minority stress and how that contributes to mental health concerns for I'll abbreviate transgender and gender diverse as TGD at times. TGD population, talk about intersectionality and gender specific related concerns. We'll talk about awareness. I mentioned before, or Dr. Walter mentioned before, that I typically present on cultural humility, and we'll use some of those principles today to ground us in how we're going to explore our self-awareness, so we can reflect on our views and attitudes and beliefs around gender, raise our consciousnesses around discriminatory belief systems about gender, and teach trans and gender diverse clients. And then we're going to get some skills. We're going to learn how to use gender affirming language, do's and the don'ts, communication strategies, how to express how to build your commitment to self-determination for the patients that you're working with or that you're going to come across. And then I'm going to leave you with some resources, and hopefully we'll have some time for questions toward the end of the discussion.
Christian, we have a comment in the chat. It says, please be sure to explain jargon, cisgender, and so on. Helpful not to assume that everyone in the audience understands.
Excellent. And I think that really brings us to our Our next point, we're going to go through the terminology right here. So we're going to, and if you have some questions, please, again, this would be the time to jump in and say, that wasn't clear, I don't quite get it, I need a little bit more help to understand, period. Okay, so please jump in. So the first thing that you should know about terminology is that the definitions of transgender related terms and constructs continue to evolve as a result of shifting usages and contextual focus of terms within and outside of the transgender and gender diverse community. And additionally, as we gain a better understanding of gender identity and how people express themselves, also language changes. So you'll see, I'm sure you've seen, people have questions about terminology. So you see here I have FTM. This was a term used in the past to describe trans men, so female to male. That's a term that's come out of favor, that people don't often use to describe their own experiences. But below that you see MTF, that is male to female. A trans woman, those are the terms that we're using now. You'll also see terms that maybe at one time were pejorative, like queer, come up as being used as ways that people identify themselves. So again, this slide again speaks to like the contextual changes of language. So you'll see that in this presentation. Some of the language that I use today might feel uncomfortable for some people to hear. They might have said, like, at one time I used this, but now I don't. So again, language is going to change, and the point I want to make here is to be responsive, listen, use what people are comfortable with, and just get ready to roll with the punches, because terms can change all the time. Okay. So first we'll talk about sex and sex assigned at birth. What those terms mean. So sex, sometimes previously referred to as biological sex or natal sex. Sex is the biological and it's typically assigned to someone at birth. When someone looks at their anatomy, looks at one's chromosomes and the hormones that they exhibit, there's typical meaning attributed to a certain constellation of anatomy, chromosomes, and hormones. And usually we're socialized to divide people into male and female. That's what I look for at sex. That's how I describe sex. Now, the sex assigned at birth, you'll see this term, I used this term to describe myself earlier on, assigned male at birth, AMAB, AMAB, refers to a person's status as male or female or intersex based on physical characteristics. Sex is usually assigned at birth on the appearance of the external genitalia. Again, assigned female at birth is AFAB, and then assigned male at birth is AMAB, AMAB. Any questions about that? All right. We'll talk through gender. So gender is a social construct that includes the roles, behaviors, activities, and attitudes that are given by society, and that society considers appropriate for a specific gender, right? This kind of leads us into our thought about gender identity here. You'll see in this sort of like this picture that I have up on the screen, it shows gender identity across spectrums. There's a female, woman, girl as a gender identity, male, man, boy, or other genders that aren't associated with male or female specifically. Gender identity is one's deeply felt inherent sense of being a girl, a woman, female, a boy, a man, a male, a blending of male and female, or an alternative gender in and of itself. Okay. I think it's an important time here to acknowledge that gender identity is not the same as sexual orientation. I think that's an important part to make. Gender identity, your sexual orientation refers to a person's sexual identity, their attraction and behaviors in relation to people on the basis of their gender and the sex characteristics of their partner. So, for instance, just to make a distinction, I think this is a good way to put it, sexual orientation is about who you go to bed with, person, and based on the gender, your gender and their gender. And gender identity is who you go to bed as, your inherent sense of being a boy or girl, whatever your gender is. Okay. Again, also, not to be confused with, when I'm thinking about gender identity, not to be confused with gender expression. Someone can have a gender identity and not feel maybe comfortable expressing their gender identity, their experienced gender for many reasons. So the way that someone expresses their gender does not necessarily align with how they themselves, their own gender identity, or what society should expect of their gender identity. So gender expression refers to how a person enacts or expresses their gender in their everyday lives and within the context of their culture and society. Expression of gender through physical appearance may include dress, hairstyles, accessories, cosmetics, hormonal or surgical interventions, as well as mannerisms, speech, behavioral patterns, names. A person's gender expression may or may not conform to their gender identity. Okay. We'll talk about the gender binary. I'm not sure if people have heard this term before, but the gender binary is the idea that gender and sex have historically been constructed according to a binary, referring to the idea that there are two and only two discrete genders. This notion erases and oppresses individuals who identify outside of the binary, i.e. non-binary people outside of the binary, or genderqueer people, whose genders are not typically, do not conform to male or female. Right, so this all, period. So again, anything outside of that is the male-female dichotomy would be the expanding outside of the gender binary, okay? We'll talk about gender transition. Gender transition refers to the process whereby people usually change from the gender expression associated with their assigned sex at birth to another gender expression that better matches their gender identity. People may transition socially by using methods of changing their name, their pronouns, their clothes, their hairstyle, even the way they move, the way they speak. But transition also may include hormones or surgeries or altering one's body. It doesn't have to. Transition can be used to describe the process of changing one's gender expression from any gender to a different gender. And people may transition more than once in their lives. Okay. I think this next one is an important concept, especially when you're thinking about gendered expectations. The idea of passing. This refers to whether someone is perceived as male, female, or another gender. Everyone passes regardless of whether the person's identity is transgender or not transgender. But many transgender people strongly oppose the supposition that all transgender people want to pass. they want to be either perceived as a male or female, a man or a woman. Some identities, expressions are non-conforming in that way, outside of the binary, again, non-binary. And the expectation that one has to conform, or that one should conform, or that one looks better if they conform, again, those are socially constructed based on one's sort of like desire and their and how they've been socialized to think about gender. All right, and the last term here is gender dysphoria. This describes a state of distress or discomfort that can be experienced because of a person's gender identity. If when a person's gender identity differs from what their physical or social attributes that were assigned to them at birth. Gender identity is also a diagnostic term in the DSM-5, the Diagnostical and Statistical Manual of Mental Disorders, that denotes an incongruence between, again, someone's sex assigned at birth and their experienced gender. And not all transgender people or gender diverse people experience gender dysphoria, the negative emotions that are associated with not the incongruence between your assigned sex at birth and your experienced gender. All right, so that's some terminology. I'm wondering if there are any questions about that terminology before I to the next slide. All right. Okay. Okay, so if someone did ask a term about transgender and cisgender, I will explain here. So transgender refers to people whose gender identities and gender expressions do not match society's expectations for someone of their sex assigned at birth, for whom this fact is central to their identities, and it is important in determining their life circumstances. So again, someone could imagine someone being assigned male at birth based on their chromosomes and their genitalia, their hormones, and they have this incongruence between being assigned male at birth. They experience themselves as female, as a woman, as another gender. They may consider themselves to be transgender women. So now cisgender, this is how I refer to myself. So these are gender identities and expressions that conform with relative ease to society's expectations for someone of their sex assigned at birth. I was assigned male at birth, and that gender assignment based on what my phenotypically what I look like, that's been congruent. There isn't much of an incongruence between that and how I experience my own gender. Okay. There are binary identities, man, woman. There are binary identities that are in the middle, non-binary, genderqueer, gender non-conforming is something that you might hear. That those words communicate that somebody's outside of the gender binary. Their experienced gender is somewhere in between or outside of the binary. Again, I mentioned the word queer. This terminology, once used to denigrate, to victimize queer people, LGBT people, has now been reclaimed and sometimes can refer to someone's sexual orientation and their gender identity. So you might see that term intertwined, and even the LGBTQIA community, queer, questioning, that's in that acronym. Agender, someone who does not identify with any gender, whether male, female, or other. They don't experience gender, don't have an internalized experience of gender. Excuse me. And then, of course, there are lots of different kinds of sexual identities. We're not really going to be getting into that as much today as really focusing on gender identity, but lesbian, gay, bisexual, queer, demisexual, lots of different, asexual, lots of different ways that people can talk about how people describe their gender and their attraction and relationship to another person's gender. Okay, and then there are intersex conditions. If we look, here again, there is intersex here. When we look at sex assigned at birth, that's when phenotypically, chromosomally, hormonally, someone doesn't match expectations of what a man or a woman might look like. Their chromosomes might be different. Their genitalia might look something in between a penis and a vagina. So that's what you would refer to as someone who has an intersex condition. Okay, so someone asked about terminology, and I'm curious about if that was helpful, or if anyone else has any questions about terminology. Nope. Great. Go ahead.
And please feel free to speak up and use your microphone. This is interactive. I know that there's somebody in the chat. I don't know if they have access to a microphone, but please, if you do, please feel free to use it and speak freely.
Can I ask something? What about those that, and maybe you mentioned it and I missed it,
Please.
that like to dress as the opposite sex?
So that would go ahead. Sorry, complete your question. Go ahead.
No, go ahead. I'm sorry.
Well, that would kind of go into, I think, gender expression here, right?
Okay, got it. Yeah.
So somebody, and again, it could be totally different from their gender identity. So like, again, I use myself as an example. I'm a man, I'm assigned male at birth. If I felt like, I felt good dressing in feminine clothing, if I felt good dressing in feminine clothing, I would be, my gender expression might be feminine, but I still identify as a man because those are just kind of different domains of someone's identity. All right. Does that answer your question?
Got it. Thank you.
Yeah.
Yes, you did. Thank you.
Excellent. Okay, any other questions? All right, Okie dokie. So we're just going to go through some mental health research, what the mental health landscape looks like for trans and gender diverse folks. So look, this retrospective cohort study where people went back, looked at an electronic medical record, pulled some data from patients that are young adults, adolescents, young adults, 12 to 29 years old, at a community health center, matching 180 transgender individuals with cisgender individuals, found that when you look at the mental health disparities, you can see visually that transgender individuals in green and cisgender individuals in yellow, that there was a lot more distress associated with depression, suicidality, suicide attempts, self-harm, inpatient hospital services, outpatient hospital services. There's just a lot more that you can see, a lot of psychological distress in transgender individuals. And it's just important to note that the psychological symptoms that people experience are not, it's not everything that transgender and gender diverse folks experience as worse. For instance, here, like when we look at IQ levels, they tend to be consistent across trans and cisgender individuals. And we look at the child behavioral checklist, something that looks at children's behaviors, how they're acting in the home and at school and whatnot. When compared to cisgender and transgender individuals, there wasn't much of a difference really seen between the populations. But again, another study showing that 53% of trans individuals met criteria for some Access 1 mental health disorder, some 42%, some mood disorder, 37%, some anxiety disorder, 50% some substance use disorder. This trans pathways study, again, seeing 75% of youth having depression, 72% anxiety, 80% with some experiences with self-harm. So there are disparities between the mental health symptoms of trans and gender diverse folks from cis people. And also something that is important to know is that there are some significant differences between individuals with autism or on the autism spectrum between cis and trans folks, where we're seeing in gender diverse populations, we're seeing something close to 11% of those individuals experiencing or being diagnosed with autism, whereas 2.3% of the general population, according to the CDC, exhibit autism spectrum disorder. Okay. Here again, we're seeing differential rates of severe mental health, suicide, again, attempting suicide. People are 3 times more likely to attempt suicide, 12 times more likely to, 12 times more likely than the United States population to attempt suicide. 48% of people have seriously thought about committing suicide versus 4% of the US population. These disparities are significant. I thought something that might be particularly relevant to this crowd would be what severe mental illness looks like. And it should be noted that there are not higher rates of psychotic disorders in transgender and gender diverse populations, but mental illness in the mental illness in transgender people first needs to be understood. It's important to understand it as separate from other disorders. And though gender dysphoria is in the DSM, transgender identity, it should not be considered a form of psychopathology. And recent studies have exhibited that, particularly when you're thinking about psychosis, the gender divergence usually expresses itself before someone's initial psychotic episode. However, sometimes the initial psychotic episode can be a catalyst for some people to express their gender identities, but that should not preclude someone from being diagnosed with gender dysphoria. You got to do a real good assessment of someone's symptoms and their experiences before making that determination. Okay. Gender affirming interventions should be initiated for patients who meet criteria for gender dysphoria if co-occurring mental health conditions are reasonably well controlled, and a patient is able to make an informed decision about their treatment and have realistic expectations. So again, just because someone does have a co-occurring mental health disorder does not preclude them from receiving gender affirming services. And oftentimes, gender affirming health care can stabilize or resolve co-occurring psychiatric problems. All right. So what I found here was the World Professional Association for Transgender Health, which puts out standards of care about gender affirming treatment. Oftentimes, insurance companies will use their standards of care to make a determination as to if someone can receive gender affirming surgeries, gender affirming treatments. They come up with all these guidelines. They came out with new guidelines in 2022, and I just wanted to identify a few of the guidelines that seemed relevant to our discussion today. So it says that mental health providers should address symptoms that interfere with one's capacity to provide informed consent for gender affirming care before gender affirming care is initiated. Mental health providers should offer care and support to trans and gender diverse people to address mental health symptoms that interfere with their capacity to, again, essentially provide informed consent before they initiate preoperative procedures, before they initiate procedures. When significant mental health or substance use symptoms are present, assessing potential negative impacts of symptoms may have on outcomes based on the nature of specific gender affirming surgeries. Note. So again,
Can I interrupt one more time?
yes.
So how do you, can you go back to the last slide really quickly? So you said that you should treat mental health symptoms that might interfere with their ability to make an informed decision, right?
Yes.
How do you deal with those that have like personality disorders that feel inadequate and at times feel a need to fit in, and you suspect that maybe their desire to transition from their, you know, sex at birth or to become a trans, I'll say trans male or female. How do you deal with that when you get a sense that someone is distressed, but it's more because of their character pathology and not so much maybe a true desire to transition into a different sex?
Again, how the World Professional Association for Transgender Health would say is that the gender incongruence needs to be persistent. So if somebody just comes up to you one day and is like, "Oh, I'm a woman," you know, it's important to consider what their experience is. But in order for them to receive medical interventions, and for that to be approved by insurance purposes, that there would need to be a persistence that shows. And if there are certain characterological concerns that you have, again, I think it's really the importance of using the integrated care team, having various assessments, seeing this person in different contexts, and really looking for that persistence is where you would is what they would suggest for someone who you suspect was like malingering or something like that. Is that what you're implying?
Thank you.
Does that answer your question?
Yeah, it does to an extent, but you know, I'm still learning and listening, and but I appreciate your answer. Thank you.
Excuse me. Hi, this is Dr. Hassan. If I can take it one step further. So the previous person that asked the question was asking about like the personality disorder and having those type of persistent symptoms. So in a scenario where we have a patient and we're treating something like bipolar disorder or MDD, and even with various treatments, we still see this persistent symptoms that are there. How long are we, continuing to treat before we make that determination that they can consent for the gender affirming treatment?
Well, okay, great question. And so if we're thinking about informed consent, the criteria for someone to be able to provide informed consent is, do they understand what they're getting into? Can they plan for the future? Do they know what the preoperative and postoperative care look like? Do they know what their alternatives are to treatment? If somebody's looking to experience some gender affirmation, have they socially transitioned? Meaning change their name, worn clothes that are associated with their experienced gender. I think there are a lot of steps. There are a lot of things to consider if someone can understand. That's how you determine if somebody can provide informed consent. So if they can repeat back to you, if they can retain the information, if they can, if it is something that is persistent, that's what you're looking for, rather than sort of say if they have manic episodes. Sure, if they can have, someone can have a manic episode and still be able to comprehend that, like, this is what I want, this is what my desires are. That does not get in the way of their ability to provide informed consent. Neither would a depressive episode, unless someone was concerned that there was some thought disorder there. That's what I would say. Does that help?
Yes, it does.
I wanted to add something. This is Dr. Casabwala, if I can, just some thoughts. So I think there's a need for us as psychiatrists and psychologists to distinguish between what is a symptom, let's say, for example, a delusional ideation of one's gender identity versus um, something that is a true, it's not related to a delusional ideation or dissociative identity disorder. Um, and then we can, here's another scenario, is that we have somebody who is truly has a different gender identity than they were born with, the sex that they were born with. And as they go along in life, they may have a predisposition to develop bipolar disorder. I'm sorry. Can you hear me?
Yes.
Sorry, I had my microphone. So those are some thoughts that run into my mind. Is like, there can be a person who has a different, gender identity. They're completely, happy with that identity, but they also suffer from depression or bipolar disorder. So treating the psychiatric disorder and distinguishing it between that and the gender identity, I think they're two different things, definitely.
Yes,
But
certainly.
yeah,
And your interventions would look very different as well.
Exactly.
Surgical and medical intervention for gender dysphoria, and then stabilizing somebody's medication, psychotherapy for maybe some access one. But thank you for your contribution.
sure. Thank you.
Is there another hand?
Yes, I'm Dr. Alder. I'm an internist. I have a few questions, but the first one, let me just ask one at a time. Does somebody have to have gender dysphoria in order to qualify for gender affirming surgery? Because there are some transgender people that don't have any dysphoria, and they would like their they would like to have some treatment. So do they really have to have dysphoria for them to qualify?
That's a great question. And if you're talking about purely from an insurance coverage perspective, insurance companies would argue yes. And I think that points to a larger issue at large, that someone's issues with gender identity have to be medicalized, looked at, pathologized, for them, in order for them to receive services that might be really helpful for their mental health. Though the answer, if you're trying to get it covered by insurance, you would have to have a gender dysphoria diagnosis oftentimes for the insurance companies to cover a procedure. If you're dealing with somebody who they desire to transition, there is an incongruence between their assigned sex of birth and their gender identity, who does not meet criteria for gender dysphoria or doesn't experience their gender in that way. Oftentimes people will they'll feel, it's less of feeling bad about not having the sex characteristics of another gender, but it's that they're really excited. There's a euphoria, there's a sense of gender euphoria when they are expressing themselves in a congruent way. So I think you're pointing out something that's a major societal issue here, that somebody has to have this diagnosis in order for it to be covered by insurance. But again, that doesn't mean that that the intervention would be any less helpful to someone's mental health. But thank you for that question.
Thank you.
All right, I think I'm going to have to move. But thank you for all the questions. Let's see.
I have a question.
You have another hand?
Go ahead.
It'll be real quick. So you indicated that, if in the presence of severity and long-term dysphoria associated with gender and discongruence, like we might consider that. But having said that, you also indicated that like social like changes might be one of the avenues to explore that. Having said that, what about like folks who don't have that like welcoming and, you know, sociocultural like context to be able to explore those like changes that, as you indicated? What about like if the environment, like the household, is not welcoming of that, even at like their physical and psychological safety are like at risk if they were to explore that? I'm like, how would you go about like in a situations like that?
You know, I'm a psychotherapist. How I would usually go about that, to have someone feel or get the benefits of being able to express themselves in a way that's congruent with their gender identity, you would find spaces where they could do that. I work with a few people who they'll bring in sort of like their hair and their makeup and their clothes to the session where they can really practice embodying their experienced gender identity. But you're really naming something real here, is that it can be really unsafe for people to explore that depending on the context. And I'll get a little bit more into that when we talk about interventions. All right. Is that helpful?
Yeah, for sure. Thank you.
Yeah. Again, at the institutional level, this is something I'd be interested to hear what people have to say about what this looks like at the hospitals that they're working at. But the suggestion is that institutions use people's names and pronouns. That seems pretty straightforward to me, but providing sleeping and bathroom arrangements that align with somebody's gender identity. That's what's recommended and it's congruent with people's mental health from the World Professional Association for Transgender Health. And also, again, as we're talking about here, I could maybe connect to the last question that we have. Health professionals should assess the need for psychosocial and practical supports for transgender people before they're getting the surgeries that they're looking for. So as a mental health provider, I'm also looking at how to support someone in having the supports they need to be able to successfully undergo a surgical procedure, per se. So I'm going to move to next. Okay, so why so much distress? Individuals with that are gender divergent in some way face discrimination, and this contributes to this theory called minority stress, where that suggests that the impact that this discrimination and stigmatization has increases the rate at which people experience psychopathology. That anxiety, that depression, that suicidality is not something inherent to that gender identity. It's a reaction to the world at large. So this minority stress theory was developed initially, it's specifically in relation to sexual identity, but is often applied to gender identity. So it says that individuals are at risk for mental health issues due to societal stigma and stress that they face as a member of a minoritized group, someone who's a part of a minority group. Whether that's here we're thinking about gender identity, but there could be minority stress applies to a lot of minoritized identities. Regular exposure to or anticipation of prejudice, stigma, harassment leads to individuals increased in mental health and physical health conditions. There's different kinds of minority stress. Proximal minority stress are things like internalized homophobia, internalized trans negativity, expectations of rejection versus things that happen outside of the person, more objective things. Like experiences of prejudice or discrimination, and the psychological mechanisms behind the negative consequences based of these biases that trans and gender diverse people experience are because of the stigma, the stress, the living in an environment that is trans negative. Trans negativity is refers to an environment that is internalizing the experience, like internalized homophobia. You take in what you're hearing from society and point and direct it at yourself. So saying my transness is bad and a reason for me to be rejected. Also, concealment of one's gender identity or expression contributes to psychological distress. Having to embody a gender identity that is not congruent with who you are contributes to a lot of distress. And you can't think about not being able to express who you are, not being able to use your resources, your family. For some reason, that can cause a lot of distress for individuals. We see, we're looking at children and youth, to give some context to what that stigmatization looks like. 78% of youths hear their families talking negatively about LGBT people, hence why there's so much concealment. Only 26% of LGBT youth feel safe in the classroom. 76% experience bullying. 90% of trans youth would describe their level of distress as often above a 5. So these kids are experiencing lots and lots of distress from society, the messages that they're getting, and that is the reason for the higher rates of anxiety and depression and whatnot. Also, 50% of trans and gender diverse people have to teach their providers about their own care. They experience people who are not competent in working with them. And there's lots of reasons why someone would not want to come to a medical establishment or be afraid of a medical establishment, because they're working with people who are not exposed to individuals who know how to treat them. 19% are refused care. 28% are harassed, have been harassed in the medical setting. That contributes to stress, not going to medical appointments, and negative physical and mental health symptoms. I was going to watch a video, a video about trans people talking from their experiences about what it's like to be in medical environments. So why don't we, let's see if I can make this work. If I can watch it. Can we hear this video?
There's no sound right
There's
now.
no sound? Oh, okay, that's fine. Well, then I'll just jump out of the video then. Again, the video was trans and gender diverse people speaking to their experience when going to medical environments, being misgendered, not experiencing, working with someone who did not know the importance of, say, them getting a PAC because of how they looked, and then that negatively impacting their health down the line. So there are lots of, so I think, again, it's important for us as people in integrated medical settings to really know what we're talking about and contribute to an environment where a trans person feels like they can come back and flourish and be acknowledged for who they are. There's lots of political stress out.
Christian, let me ask you a question. Do you want me to try, if you email me the link, do you want me to try to pull it up and I share my screen? It may not allow you to play it because it's within your slides, but it might allow me to do it because I don't have a slideshow up. I'm not sure. I'll wait. There's another video that's a little bit, I think, better than that one. And we're getting so many good questions that I'm worried about getting through, but I appreciate it. So keep on asking the questions, but I'll sacrifice the video for that.
Okay, and then we had a question in the chat. If we can't watch the videos, if you could share with me the links, that way I could send them to the people and they could watch it on their own.
Of course, I'll send you I can send that out.
Awesome.
To everybody.
Thank you.
Okay. Yeah, but there's another video I might try to send you. So there are lots of political stressors. The socio-political environment that people live in the trans and gender diverse people live in. There's legislation and policies attacking their rights nationwide. Anti-trans bills are on the rise. Over half of LGBTQ individuals live in states with hostile policies and that are rated low in terms of being supportive of individuals and their gender identities. Again, also contributing to anxiety, fear, and depression. I wanted to speak to intersectionality for a moment here. And what intersectionality means is that, so trans and gender diverse people are a part of one, at least.
The very boost.
The
state doesn't provide. It was a special order with a special request, with a special plea that we.
Okay, hold on, I'm trying to find, there they go. There's, oh wait, can everyone make sure they please keep themselves muted if they're talking? I can't, there's so many people in this meeting, there's 226, that it only allows me to see the first 100. So if it's somebody in the second 100, I can't mute them.
Whew. Okay, thank you. We want to also speak to intersectionality and how that can influence someone's mental health sort of symptoms. So the idea of intersectionality is that trans and gender diverse people already belong to a minoritized group, right? So if they belong to, say, another minoritized group, whether that's based on their race, their class, their religion, their socioeconomic status, there are additional compounding, interacting, overlapping oppressions that they might experience. This idea of intersectionality was coined by Kimberly Crenshaw, a legal scholar and a civil rights activist, who was explaining the differences between Black women in the legal system and what they experience versus white women and men. But what she noticed was that, again, a way to kind of understand the experience from the perspective of one's social environment, and that individuals are shaped by their intertwined social identities. So as a Black woman, you might experience depression, and as a Black person, you might experience depression, and as a woman, you might experience depression. There's compounding and interacting impacts that might have on someone's. So, and the interdependence of your identities interact with the social and structural sort of powers that exist. These systems and structures of power help to create and perpetuate oppression, especially when they're compounding and overlapping. Again, it's important to, just makes it important to remember that people of minoritized gender identities, if they do happen to be a part of another minoritized group, it's important to look at those intersections and overlaps of the oppression that they feel, because those may compound or contribute to the mental health and physical health issues that people are experiencing. Okay, so this is also a good point when we're just thinking generally about transgender and gender diverse people, is that it's not, I've been really highlighting some of the detriments that the society that we live in contributes to their mental health, but there's lots of coping and resilience in this population as well that I want to focus on and highlight. A lot of the research around transgender and gender diverse folks really initially focus in on pathology and unhealthy behaviors like substance use, sex work, that sort of thing, depending on how you're using it. And we could see that when people cope in ways that are more adaptive, that can lead to, this is a very resilient population. There's lots of community and support and ways that people can support themselves. But again, here we see substance use, self-harm, ignoring the problem, in response to discrimination and stigma. Those are associated with negative health outcomes and anxiety and depression, whereas better health outcomes are associated with accepting support, seeking out support, utilizing agencies, and increasing your protection of yourself, self-efficacy, and self-acceptance. These are ways to intervene, points to support the trans and gender diverse people that we work with. Themes of resilience that were found in this study that I'm referencing here are having an evolving definition of yourself, embracing your self-worth, understanding minority stress, and that some of the negative feelings that you're experiencing are the external environment are contributing to that. It's not just only coming from the inside. That's really important when thinking about, or an important thing to contextualize when working with trans and gender diverse folks. Connecting with a support community, building hope for the future, being an activist, and being a role model are also ways that people can build their resilience. So again, having some assertiveness and confrontation skills, as well as building community, are also great ways to build your coping and resilience. This is the transgender resilience intervention model, and it refers to several of the concepts that we've been talking about here today. So those distal stressors from that minority stress theory, you see the proximal stressors, you see how these distal stressors like gender-related rejection, victimization, non-affirming gender identities, contributes to concealment and rejection and internalized transphobia, and then to negative mental health outcomes like anxiety, depression, suicide, and substance use history. But if we look here, there are several interventions at the bottom, at the community level, at the group level, at the individual level, individual therapy, group therapy, advocacy, and education that can, this model suggests, can make changes, can moderate the negative impacts of these of minority stress. Okay. All right. So it all comes down to, so trans folks they need care. They should be provided with quality care, and we can be creative and have an obligation really to creating a safe and affirming environment for the individuals that we work with. So now we're moving on to kind of building some skills. What can we do given all of that information, all that context that I've just given here? So I'm going to be speaking to what gender affirming care is, and as like a theoretical concept, and then practically what you can do, ways to create gender affirming environments. So gender affirming care encompasses a range of social, psychological, behavioral, medical interventions designed to support and affirm an individual's gender identity when it conflicts with the gender that they were assigned at birth. The interventions help transgender people align various aspects of their lives, their emotional, their interpersonal, biological, with their gender identity. So again, I mentioned gender transition, whether that's their changing their name, whether that's dressing in a way that's congruent with their gender identity. Gender affirming care supports that with the people that we work with. Gender affirming care is an approach that emphasizes validating the diverse experience of gender identity and expression. Now, the next point here says that gender diversity is not pathology. It does not equal pathology. Because someone has a gender identity or a gender expression that is not congruent with traditional expectations of male and female and what that means to be, that is not inherently pathological. Gender affirming care sees that and wants to validate that for our patients. For most transgender people with or without severe mental illness, their dysphoria is alleviated by achieving a satisfactory level of affirmation of their gender, again, through social, legal means, evidence-informed gender affirming health services. Many transgender people will require both hormones and surgical interventions to alleviate their gender dysphoria, while some will not. And then that's an important part here. We're really just meeting a person where they are, responding to them, having the understanding that there is diversity. Not everyone's transition is going to look the same. And that it's really, client focused, person focused, individual focused. Okay.
Christian, we have a question in the chat.
Go ahead.
It says, based on your experience, would you say the self-harm and other behaviors are all new, or maybe it says known, as a result from gender rejection, or do they usually have self-harm and other negative behaviors beforehand when stressed, and this is just a stressor?
It's an interesting question, and I'm not sure if I can. It would really depend for someone, because sometimes you work with trans and gender diverse folks, and they are totally accepting of their gender identity. They have supportive networks. They're not struggling with how society is seeing their gender identity, but they have severe depression that is not associated with their gender, that contributes to why they engage in self-harm, or they have trauma in some way. But then you have some people that the distress that they experience, the way that they're coping with their gender dysphoria is through self-harm. So it really is an individual thing. And I don't think I could really speak to a percentage of the clients that I work with. But again, that's what speaks to this, the importance of this individualized care, is really looking at what's going on for somebody. Is this depression? Is this gender dysphoria? What are these these maladaptive coping strategies associated with? I hope that helps to answer the question. Okay. The basis of all trans affirming care is the respect for self-determination. Again, what somebody, their thoughts, their desires, the experience of their own gender identity, then be able to make decisions for themselves, saying that they have the agency, the mental capacity to do that. That is what gender affirming care is, and helping people make decisions that align with who they are. I think is a very important point to make here. And there are certainly ways that there are coming up here, we'll see. There are ways to support individual self-determination. And I think the biggest way, really, and the way that we're going to focus on today, is in the language that we use. We refer to someone's name, their pronouns, their identity, their designations, greeting, talking about transition, and talking about people's bodies. Great. Language matters. Trans and gender diverse people experience frequent harmful speech, and the emotional impact that it has is anger, betrayal, discomfort, nervousness, it's traumatizing, this hopelessness, exhaustion that comes with being inundated with these non-affirming language. And using language can minimize the trauma from these microaggressions. So we're going to talk a little bit about names here and strategies for you to engage in gender affirming language, affirming language. Here we go. So one strategy is to ask what someone's name is, or the name that they want you to use. Never use a given name without permission. Never ask what someone's given name is unless it's absolutely necessary. and that's usually for insurance purposes, where that might be necessary. And there are ways that you can ask for that we will go over. Refrain from putting chosen names in quotation marks as if it is not someone's actual name. Have the client write down spelling of their name rather than having them say it out loud. When you're asking for their given name. And when referring to somebody pre or post transition, use their current name. Those are ways to be affirming. I am who I say I am. Some people may use a different name to refer to their younger selves, but that's something to ask someone about. But use someone's name when interacting with them. So examples of things that you may not, that are non-affirming. What is your preferred name? Okay, I see a question here. Or someone has their hand up.
Yeah, this
Go ahead.
is Dr. Alder. I just want to know what the issue is with, what the problem might be with asking the person to say out the name loud, because you want to get the proper pronunciation also. So what will be the problem to ask him to say the name loud?
Asking somebody to say that their given name, the name that they're given at birth, and that they are no longer using, that can be really upsetting to people when they're trying to separate themselves from that name. There would really be no reason that you would have to say that name to them out loud in front of them. So I think having a documentation, again, there may be very limited reasons why you might need to know that name. And that may be insurance purposes, sometimes even in psychotherapy. I found working with that name, that part of themselves can be necessary, can be helpful. But again, I would only ask that question or get that name if it was pertinent to what was going on.
No, that's not what I meant. What I was asking is, if there's a preferred name, there's a new name, are you saying that one shouldn't ask for them to give the right pronunciation?
No, sorry. I was maybe I wasn't clear. I was referring to their old name in terms of asking them to write that down. In terms of their new name, of course, the name that they've chosen, chosen name, feel free to ask them how to say it, how to spell it. That's, I think, a really affirming thing to do.
Okay.
I think it's pretty evocative that a lot of these folks refer to their given name or their birth name as their dead name. That's really, in the parlance, that's what people call it, is their dead name. That says a lot.
And I thank you for that comment. I think I was a little far away from the reality of that, and that is true. People, depending, and it really depends on who you're working with. I don't necessarily use the name dead name to describe someone's given name all the time, because sometimes people have positive relationships with that part of themselves, and that part of themselves is not dead, but like integrated into who they are. However, there's a large contingency of people who do use that word to describe the name that was given to them, and that is correct. The calling it a dead name points to the severity, the intensity with which people regard that name. I see another question, two questions maybe. Jump in. Thank you. I hope that answers your question. All right.
I have a quick question.
Go ahead.
So in an evaluation, sometimes, you have file information and you'll see historic documents, and it's not uncommon to ask someone if they've ever gone by another name, an alias or another name. Is that considered insensitive in these cases?
I think that's a reason why you'd want to know that name. That's a reason why you might need to know, if you need to get records or something like that. You might ask. You might say, "I saw this name in your chart. Was this?"
Exactly.
Right.
Because it's a factual piece of their history. But
right.
Would it be appropriate to refer to that name as a name given at birth, rather than
name given at birth, legal? Even if it is their legal name, it's interesting too, because I'm thinking about, because if somebody got a name change and sort of their legal name was congruent with the name that they chose, that might be less of an issue. But you might have to refer to, like if old documents had their given name on it, you might have to refer to that or explain that in some way. So yeah, but that would be an appropriate question to ask someone for them.
Okay, great.
I also really like the way you asked that, because you didn't say what name you were you born with. You said, have you ever gone by another name? There could be a wide variety of reasons, and that's kind of a nice, gentle way to introduce the question.
Excellent. Yeah.
I usually also just, I straight up ask, like, so, I'm so and so, what do you like to be called? And then once they give me that, I do tell them, like, okay, well, thank you, so and so. I know that in the past there was chart and information with this name, and I guess I take it from there. But it's
That's a great way to ask. I agree.
I'm sorry.
So again, here are ways that aren't so affirming to ask. What is your preferred name? I wonder if anybody can speak to why the word preferred name might not be affirming.
It suggests it's not their name.
It's like what? Go ahead.
I think it could be like very invalidating, and as if like they chose this, like, right? I think there is like a lot of biases and prejudices that like people choose that like quote unquote lifestyle when it's like their like core identity. So I think that like, oh, what is your preferred name? It sounds like it's denigrating almost.
Right. Just a choice, just something I prefer. Chosen name. What is your name? I think those are the ways to those are ways to really refer to what someone's name is. What is your real name is not an affirming thing to say to someone. I knew Jay when he was Jenny. Like, what's the point of the reference to Jenny? Again, what name do you go by? Excellent. I've known Jay since he was a teen. Obviously, you can say that. All right. Let's move on to pronouns. Again, I introduced my pronouns as he, him initially. But using incorrect pronouns is a microaggression. Way to invalidate someone's existence, their relationship to their gender. When you make a mistake, correct yourself and move on. There's no need to cry, to make a scene. In a situation like when you use someone's incorrect pronouns, and you're the one that's overly responding to this, it changes a situation that was about this other person, where they were impacted negatively by something that you did, into the attention's on you and how to support you. There a question? Okay. Period. So on some of your intake paperwork, it's important for you to have, go ahead with the question.
So I have a question about this, because in lieu of complexity of pronouns, I think that there has been like a movement where like pseudo like pronouns, as if like this was like a joke to them. Like, I was wondering if you ever had encountered those like situations where you had to address like pseudo pronouns. Like, I've heard like, so like I just wanted to hear if anyone has like experienced that, and then how you would like clinically address the issue.
What kind of pronouns are you thinking about?
Like, I've heard people call themselves like zebra. Like, that's a mockery, right? Like, so like in situations like that, like, I don't know, like I've tried my best, but like I think that like I get really upset, and then like the point is to get them to understand why is that wrong. So like, I would like to learn the tools to address this pseudo pronoun, like, yeah.
Well, yeah, I mean, I guess, you know, it really depends on your relationship with the patient, what this is an indication of. You have to be very certain that this person is not exhibiting, is not exploring utilization of pronouns that are consistent with their gender identity before making an intervention that way. But I think you know, having a serious conversation with somebody, or is this how you're identifying your gender? These are the pronouns that you would like to use? Yeah, I've not really come across that too much with somebody who I'm working with that experiences gender dysphoria.
No, I'm not talking about like those who are like exploring their, like, I'm not talking about bona fide like gender like exploration. Like, as a mockery, it was very evident that like it was a mockery to you know, the continuum of gender identities that exist. And I don't like those conversations. Like, I often like found myself like really upsetting for me, and like it was just like an unproductive conversation. So I was wondering if like anyone has encountered that, like how to address those issues and so on.
I've not. I'm wondering if there's anybody that can speak to that.
Oh, Young, are you talking about people who like just randomly make up
Right, like
pronouns
I've
and ask
heard
you
people
to
say
address
that, oh,
them that
I'm a
way?
zebra. Yeah.
Because it's a way of making fun of people who do have
Right.
different
It was
pronouns.
it was very clear that it was a mockery to the population. And yeah, it wasn't like actual, like, you know.
And for me,
So-
my thought, I would probably
um,
really explore what is going on, what that means, what they're trying to communicate. That seems like a psychological intervention in some way for me. Or, you know, depending on the context that you're in, if it's a mixed environment, period. If this is someone saying this in a group, this is something to address. This is serious. This is not no way that you talk about or refer to another person. And you know, whatever consequences follow from there. It's kind of how I would go about it. But you know, you would have to be very clear that this is not someone. It sounds like you're very clear that this is just mockery, but you'd have to be very clear. Is what I might say. Any other thoughts?
I was wondering if you have some advice. We have staff who have expressed concerns about using pronouns of a person who identifies differently than their religious beliefs allow, if you will. So I've gotten feedback that I can't use those pronouns, or I can't use that name because my culture or my religious beliefs don't allow me to. And we are trying to be sensitive to everyone while at the same time being affirming, and educating our staff is something we would like to try to do. And that's something that, you know, we struggle with a little bit because, you know, it's difficult to have the conversation. So do you have any tips for how to engage in that conversation?
Well, you know, I think even a part of this this training, we'll be exploring our own genders, our own gender training, where it came from, the impact that it has, that society has on how we orient ourselves toward gender. So I think that's one way, through education. But I think also being very clear that using this language is harmful to the patients. And I think, you know, I'm working at a hospital or working with whatever agencies that we're in. I think the commitment to supporting the patient's care, I think that is kind of is the perspective that I might take. You don't have to. You know, there are lots of ways to talk about people. You can always use somebody's name. John went to the bathroom. John did this, as opposed to he or she when you're talking about pronouns. if someone's uncomfortable with using pronouns specifically. But I think, I'd have to hear a little bit more about the rationale why someone would not want to use someone's name or their pronouns. But I think, yeah, commitment to supporting our patients' well-being based on recommendations from professional organizations is kind of where I would go.
Thank you.
I'd like to jump in real quick if I can. I can't seem to raise my hand. I mean, this is maybe a superficial example. So pronouns are more. I'm sorry. So pronouns? Did I say pronouns, or am I using the right term right now? But to identify one's gender identity or how they identify, we as a society do a lot of that of identification for other things. I am Mr. So-and-so, I'm Mrs. So-and-so, I'm a doctor. I prefer to be called Dr. So-and-so, or I prefer to be called by my first name or last name. Or many examples. A friend of mine said, "Oh, you're Asian." I said, "No, I'm not Asian." He says, "Well, you're from," I said, "I'm South Asian, East Indian. There's a difference." Oh, well, and he disregarded that. And I told him, I said, "This is what I prefer to be called. This is what I identify as." And it was invalidating, or just, if I felt disrespected. It wasn't too much to ask for, but so how would I? So if I told him, if I approached you and said, "Okay, are you American or whatever, how you identify with," it's showing respect. But because it's a relatively new language that we're using, I think generally speaking, people become uncomfortable with change and a new way of addressing each other. But throughout the centuries, we've had different forms of address. In some cultures, you refer to your older sister or brother as, there's a special name for it, and that's expected. We respect that. Those are some, superficial examples.
Well, I would say, honestly, they're not superficial examples, and I really appreciate you saying that.
Thank you.
You're welcome. Even in the recommendations that I'm giving, I kind of went a little authoritarian here, but coming from a place of understanding and compassion and helping someone see someone else's perspective, I think those are great ways of intervening with somebody who's having a hard time understanding how to use these new neo pronouns or whatnot. So, I agree. And then, so, that is definitely a way to do that, to use the team as support, to say that we're going to learn how to do this together. There's going to be a shift in the culture. And, I'm also hearing sometimes you'll encounter people who don't have the best intentions. The issue is not that they can't learn to do it, it's that they don't want to do it. And they can't quite see, but again, coming from a perspective of compassion, understanding that people are learning, they're doing their best, that can be a really good way of working through this.
Dr. Creedle, just to add a little bit about this, because I know that when you introduced this particular topic about pronouns, you said that misusing pronouns can be a microaggression. And, for centuries, we have been using, pronouns based on a lot of us based on how people look or their appearance, right? And a lot of times we do get clients or patients that look a certain way, but then they say that their pronouns are something else. And naturally it's not something that comes natural to me, and it is something that I'm learning about, something that I'm open to learn about, because it's important, right? It's very important, and I want to treat everyone with respect. But me making a mistake, I don't quite see that as a microaggression, but rather, a process of learning to to deviate from what my brain has been taught versus what someone wishes or someone wants, how someone wants to be addressed. And I do want to treat everyone with respect, of course. That's important to me. However, I'm also a human being who has been taught certain things in this society. So I don't quite see it as a microaggression, but people make mistakes. And
so what I would say is that when I think about a microaggression, it really has less. It doesn't necessarily always have to do with the intent that someone has. Calling something a microaggression really refers to the impact that it has on another person. So naming it as a microaggression is not saying that you're trying to hurt somebody. It's saying exactly what you just said. You've been socialized, you've learned how to address somebody in a specific way from society. We live in a binary society, and sometimes there are things that we have to unlearn, or ways that we have to expand the ways that we see other people. It sounds like you have a commitment really to respecting people. And what you might do is, if you mess up somebody's pronouns and you don't remember, as this last point here is, you would someone would gently correct you or incorrect you, not to to take the burden off of, hopefully, once we do this presentation enough in a different context, there's a culture change, and you don't have to do it by yourself, and you can have other people that support you. And then when you get the feedback, you go, oh, I apologize for using your wrong pronouns, and you kind of move on. So I think it sounds like, and again, just maybe the word microaggression, I could have gone into a little bit more description about, but again, microaggression, being committed, doesn't say that you're trying to commit or trying to hurt somebody. It's just that it has that negative impact.
Yeah, Dr. Credo, this is Dr. Alder, and I think I agree with you, and I agree with the last speaker in terms of being microaggressive. When you're microaggressive, you will know. The idea is that when you see these patients, you want to show respect, understanding, compassion, and the idea is to build up rapport. I've dealt with many transgender patients, few of them in the hospital. They're not looking for you to be perfect, because some of us that are older, we're still trying to get all these things right, from he to she, they to them, and all this. Younger people, they're very fluent with this. But the older people, sometimes you're going to be saying she. All of a sudden, you find yourself saying he. Your patient is not going to just hold you responsible for that, or you're microaggressive. It's the overall kind of interaction you're having with them, and they will. That is my experience. They're not going to judge you based on that, because they already know that you are trying your best, you are focusing on their health, and you're not doing all these things intentionally. That has been my experience. It's not like people are so fragile, and all of a sudden they're looking for you to make mistakes so that they can say, oh, you're homophobic or you're transphobic. I don't think that is what is going on.
And what I pull out is you cannot avoid making mistakes. You can't. You can try your best. You can educate yourself. You can commit yourself to contributing to the healing of this specific population or any population, and respecting them. And that's all you can do is do your best and correct yourself and move on, I think. And when you do that, when your patients see that you have a commitment to doing that, that contributes to positive health outcomes. Is what I've experienced. But let me jump in here. Let's see if there's anything else that I wanted to say. Again, non-affirming, what are your preferred pronouns? Again, do you use male or female pronouns? Non-affirming, they're more than just male or female, masculine, feminine pronouns here. What pronouns do you use would be a affirming way to say that. My pronouns are.
Hello?
Go ahead.
Can you hear me?
Yes.
This is Christina Cleo. With the religious thing, I just want to say, because I do some volunteer activities sometimes outside. I've been doing them for years. So I'm part of this one organization, and we incorporate religion, and we have Muslim, Jewish, and Christians that are, that are part of the LGBTQ. So even religion's moving into more accepting, because in New Jersey, there's a transgender rabbi. In New Jersey, we have a transgender minister. So we're trying to, what I do on the outside is incorporating where a person doesn't have to pick one identity over the other. They can unify. It's just working on being more open-minded, more accepting about it, and being kind and very empathetic. And it's been very successful, and it's really helped a lot of the youths in the community.
And I love this point that you have, is that oftentimes, depending on the religion, the expression that somebody has, there are individuals of that religion who use someone's pronouns or who can use someone's correct name. So there are ways to go about it. Maybe that might be a recommendation to explore parts of your religion that are accepting. Find community, find some examples of people that are able to kind of put those two things together, their religion and respect for people's self-determination and their names and their pronouns. So there are ways. But I appreciate that comment, Christina.
I just want to jump in real quick. This is a great discussion, by the way, and very informative. This concept, relatively maybe perhaps new to Western society, is an ancient occurrence. Even in ancient India, in our culture, we've had groups of intersexed, transgender, cross-dressers, a combination of thousands of years old culture, and they use different pronouns to refer to themselves. So it's not a new phenomena. I think we're not used to it in this current stage in our humanity, but it's it's also in our Hindu Hindu mythology or Hindu religion of these ideas. This is quite interesting. I just want to give my 2 cents there.
I appreciate it. And again, this isn't new. It's not new. It might be newer to certain people, certain parts of society, certain experiences. But you're right. There's been gender diversity throughout all of time in ways of and different ways to refer to people. We just got to incorporate that old knowledge. I'm going to move on to the next slide, but here are just an example of some of the pronouns that people do use. She, her, hers, herself, he, him, his, himself, they, them, their, themselves, z, zir, zirs, zirses, here's is. They're different uses. These are just like some examples of pronouns. And one thing that can be hard for people to practice or to hold on to is that sometimes they feel like they don't know how to use the pronouns. They don't know how to refer to someone. It can be a really powerful intervention or experience or relational moment for you to ask somebody what their pronouns are, how to spell them, and how they would like them used. That can be one thing, the first time you meet with people. And then also, again, the luxury, I really appreciate the luxury of working in integrated settings. You have colleagues who you can practice these things with outside of the patient before you're working with a patient so that you can get it right. So these are, again, just something to practice. And again, here I want to point out that they, them, there's gender neutral pronouns that you can use to refer to people if you're unclear about before you know what their pronouns are. And also introducing, I think I skipped this here. in a group have people introduce themselves with their names and their pronouns, that can speak to your commitment to changing the culture of a place and respecting people of varying gender identities. I see there's a question. No? Okay. I'm gonna move on. Okay. Gender identity or designation. Use gender affirming terms. Listen for and mirror the language that a patient uses. Do not assume based on someone's appearance, their name, or their pronouns. Somebody made this comment before. It can be difficult because you have these expectations about gender that you've lived with your entire life, and there's something that you're seeing some person that's incongruent with what your expectations are. It's a good thing to try to say, okay, even though this person looks like a woman, how I would conceive a woman to look like, that might not be what their gender identity is, and you might want to think about that before you call somebody out. Avoid using language that would reinforce the gender binary. We'll get to some examples of that. And then, just approach asking about sex assigned at birth with caution. Think about when you have to ask the question. Is it necessary? Is it something that you can look into the chart? Why are you so curious about this? If you're just, giving somebody like a flu shot or something like that, like what might that have to do with what you're doing with the patient? So instead of using terms like biological male, female, natal male, natal female, bio male, bio female, those sort of things, born as a man, a real man, again, sex assigned at birth, designated male at birth, designated female at birth. Those are some terms. Cisgender, transgender, those are the terms that you want to. Okay, again, things to, instead of saying opposite sex, you could say another sex. You'll see these, there were some, for those of you who are curious, I suppose, there was some significant changes from the Diagnostic and Statistical Manual 5 and the 5TR, and it upgraded its language to reflect this, another sex or different sex rather than opposite sex. Both sexes, ladies and gentlemen, like that sort of thing. You could use all genders, everyone. Sometimes you guys is something that slips out of me all the time. But again, those are different terms that you can do, everyone. Again, MTF, male to female, that would be a transgender woman, trans woman, trans feminine person, trans woman, that kind of thing. And the same with FTM, female to male, a trans man, transgender man, trans masculine person. Okay. Greetings. We were referencing this, I think in some way before, but adopting gender neutral greetings for all. Until you know someone's gender, the pronouns that they use, their gender identity, using gender neutral pronouns is something that you can do that can be gender affirming. Refraining from assuming the group composition, you could be around people that you assume are a whole bunch of women or something like that, and that might not be what the reality is. Changing your demographic forms, that's more of an administrative thing. And then, let's see, use gender neutral descriptions when you, it says descriptions. So yeah, using gender neutral pronouns. I don't know who they are. Who's that person over there? Here's some terms that you can use. Hello everyone. Hello everyone. Hey everyone. Hey folks. Hey friends. Sure, I can do that. Use someone's name. That is always good. Dear, first name, last name. You all. Use. Some people say use. I like that. As opposed to ladies and gentlemen, you guys, hey ladies. This one, man and sir, can be really, I think, difficult for people because people associated the usage of those terms to refer to people as a way to respect people. And it can be really difficult, again, when you're like, I use that term to respect people, but I'm receiving the information that is actually disrespectful to make that assumption about them. So again, wait until you know someone, and if they like to be called ma'am or sir, feel free to do that. But I would just making the assumption off that is not the not gender affirming thing to do. Always ask. Okay. And again, when describing someone's transition, don't assume that all trans clients relate to the concept of transition, or specifically, a medical transition. Not all people want to do that. Not all people want to do this social transition. Not all people want to change their appearance. You really just have to take it on a person-to-person basis. You can assume that people have access to transition-related care. Medical information and histories are sensitive. It may not be relevant to your work. So again, just being very sensitive of like, why am I asking this question? Does it pertain to what I'm doing? Thinking about, would you ask a cisgender person about, say if somebody had a medical transition in some way, like if somebody had a procedure, would you necessarily ask them about it? Could there be something private about their experience? Thinking about that as a way to kind of filter the questions that you ask to people. Avoid using terms such as pre-op and post-op. Again, this leans into the idea that transitions are all medical. It's all about the body changing. People have an obsession with trans people's bodies, and we want to kind of move away from that. This example of non-affirming: have you had the surgery? You should pre-op or post-op. The question that you could ask to somebody is, what form of transition are a part of your path? Are you interested in a medical transition? Okay. Now, communicating about bodies. Again, starting off using gender-neutral pronouns, I think is always gender-neutral language. Again, is always a good place to start. So never ask a trans or gender diverse client about their genitals unless you have a legitimate reason to do. Again, use the as instead of your. When referring to somebody's, you can. This can be some way to be gender affirming, because at times people can have dysphoria about different parts of their bodies. The chest, the breast, if somebody's referring to that part of themselves, the lower body, and until you're able to get some language about how comfortable someone is with certain language. And be mindful of discussing body parts that can be sort of upsetting or part of somebody's trauma. When in doubt, ask and mirror language again. Always asking, using language that someone says is important. Be mindful of sex-specific medical information in the electronic medical record, what you keep in there, who has access to it, that sort of thing. Instead of using breast, penis, vagina, male, female, reproductive organs, you can use more neutral terms like chest, genitals, private parts. You can name a specific organ, facial hair, talking about, again, the cervix, the uterus, these things. Name a specific part. Okay. Again, some affirming language to be aware of, and some non-affirming language to be aware of. All women need to have pap smears. Again, some men have vaginas and may need a pap smear. So you're not including those people. And then let's see. Yeah, I hear that you want top surgery, that can be a way to refer to a procedure that someone's looking to get, as opposed to, I hear that you want to have surgery to remove your breasts. Yeah. Right. Again, if mistakes are going to happen, make the mistake. Making a mistake may bring up very difficult feelings for you in the moment. Just correct yourself and move on. Later, get the support that you need to deal with the feelings that come up for you. Is how I would go about it. So, oh my God, I'm so sorry. I can't believe I just used the wrong pronoun. I just used the wrong pronouns. Such a terrible person, not necessary. I'm sorry. I meant they. I mean they. Move on. Again, just the key points here. Use inclusive language, avoid assumptions, ask people about their gender and their sexual orientation, use terms that the person would use themselves, be careful and avoid reinforcing the gender binary, the thought that people can only be men or women. Ask about gender identity to the extent to which it's relevant to what you're doing. Always discuss, I guess depending on what your role is, the diagnosis that you give to somebody, document what things are going to be, what things are going to look like on their documentation, the fact that you might need some information for insurance. Again, do not use disrespectful language, stare at people, express surprise at somebody's appearance, or gossip about patients. Save your curiosity for Google or somebody else. Okay. So we're going to move on to talking about awareness and how we can use sort of our experiences, our internal experiences, to help us sift through our biases. Now, Dr. Waldron, I'm wondering if I could send this to you, actually. If you're still here. So, can everyone still hear me, by the way?
Yes.
Yes. Okay, excellent. All right. Share. Okay. Window. Yeah. Interview. Right. So we'll see if Dr. Waldron can show us, but we're going to talk a little bit about cultural humility. I hope that people have heard of this term before, but it's a framework that was developed for us to talk about systems of oppression and the patients that we work with, developed by Dr. Turvalon and Dr. Murray Garcia, who you see on the slide. So cultural humility is often in opposition or in comparison, they're not totally opposite, to cultural competence, which is a detached mastery of a theoretically finite body of knowledge. So say if we just did the presentation and I said, okay, so like, about trans people and, go off, that's it. It's saying that there, you can know a defined amount of knowledge about someone and be an expert in who they are. Cultural humility takes the necessity to know information about the groups of people that you're working with and adds on a couple of elements here, several elements here. So it's a lifelong commitment to self-evaluation, self-critique, to readdress the power imbalances and the patient-physician dynamic, and to develop mutually beneficial and non-paternalistic, paternalistic meaning like kind of like fatherly, top down, like I'm the expert, I know what to do, I'm telling you what to do, clinical and advocacy partnerships with communities on the basis of individuals and defined populations. Humility divides itself into three different dimensions. We're going to be really looking at lifelong learning and critical self-reflection as it relates to self-awareness, but then there's also recognizing and changing imbalances and making institutional accountability. Lifelong learning and critical self-reflection, when you come from a perspective of not knowing. I do not know your experience. I don't know what your expertise is, what you know about yourself. That's integral and important in your treatment. Being able to accept one's limitation, you really just letting go that you have to be the expert. You are encouraging curiosity, again, tied to not knowing, it's openness. You're open to learning about others. It's a lifelong critical self-reflection, holding yourself accountable to continue to learn and have curiosity. And again, it frees you from that expert role. And you don't lose your expertise, but it does free you from having to be that person because you're collaborating. You're building collaborative relationships with the people that you work with and the communities that you serve. All right, so we're going to do a little bit of an exercise. So feel free to grab a piece of paper. I'm going to ask you, or type if you're in front of your computer. Open up a document where you can write. All I'm going to ask you to do is just have some genuine curiosity, and then maybe we can get a few people to respond to the prompts. So I'm going to read here. So imagine in your mind a man and a woman. Don't think too much about it. Just go with the first images of it and the image available to you. Hold those pictures in your mind. Notice what physical and personality characteristics these imaginary figures have. Notice the racial and ethnic background of these figures. Notice their bodies, shape, and size. Then ask yourself, why these images or representations for men, women are most available to you? Notice how you feel about the representations, including how you feel about it compared to yourself. Imagine what it would be like for a trans client to compare themselves to these images. You give yourself a little time to write. I have another prompt. I'm going to bring up this next prompt. Now bring up a picture of a trans man and a trans woman. Don't think too much about it. Just go with the first images that's available to you. Notice the physical and personality characteristics these images, these imaginary figures have. Notice the racial and ethnic backgrounds of these figures. Notice their body shape and size. And ask yourself why these representations for trans men, trans women are the most available to you. Imagine what it would be like for your trans clients to compare themselves to these images. So I'm I'm curious if anybody could speak to what they noticed about the images that came to their mind.
I can speak to the first one.
Excellent.
Sorry, I don't know if my mic is okay. Obviously, it was a lot easier for me to think of the first one. The first picture that jumped into my head was myself and my wife, and thinking through that, and it's like, okay, do I think I do a pretty good job of meeting whatever that is? As I'm a guy, and thinking about that, we don't necessarily fit a lot of traditional kind of roles and what our jobs are and what we, how we handle stuff at home. And I'm thinking, well, look, we're nice and diverse and not always fitting into the roles real tight. And it was a lot harder trying to kind of move that and get a picture in my head of a trans person. And, I struggled a little bit with that.
It's less a part of your conscious awareness of who you see, the models that you have. So someone's life experience, a totally different maybe from yours, harder for you to pull in some ways.
I can also share my experience.
Please.
So just like the other gentleman, I saw a cis woman as myself and a cis man as my partner. But when it came to a transgender woman, I actually saw it as a woman, but a transgender male in my brain, it looks more as someone who's still transitioning. Hasn't fully gotten to a point where they look like what society has described as a male, as a man.
So that passing sort of like structure was a part of where your brain went.
Yes, like I've seen trans females that I cannot really, I wouldn't know that they were trans if they didn't say it. But in the experience of my eyes, most or a lot of trans men that I've seen, I can kind of tell that they've transitioned or they're in the process of transitioning.
So in your mind, there's a radar where someone is in their transition, where they could be, where they're going.
Well, not quite. It's just like I see someone and then they tell me I'm a trans man and I'm like, oh, okay. I'm sorry, a trans female. I'm like, oh, okay. Well, I wouldn't have known if you wouldn't have told me. Whereas the trans males, the trans men, I feel like most of the times it's a little bit more obvious that they've either transitioned or are in the process of transitioning.
Thank you for your.
I don't know if that made sense.
Well, I think it really pulls from that one concept we were talking about before. So when you're thinking about trans and gender identity, passing, what someone looks like, where they are in the tradition comes up for you. That's thank you. I guess I'm curious if anybody noticed any bias about gender or transgender people. Did they notice in the exercise? Any biases that came up for people?
I noticed that when I pictured the trans people that I know and that I have known, what came up along with that image was recollections of criticisms or making fun of them that I've heard from other folks in my life.
Really, that experience of trans negativity, transphobia was associated with that, with the images of trans that came to your mind.
And just being defensive on their behalf, but that's another story.
Sure. Maybe there's a protective part of yourself that kind of comes out when you think about a trans person. That's not an uncommon experience. So I don't know what your gender identity is, but particularly for cisgender people, I saw a hand go up. And I
Hi,
can't. Go ahead.
my name's Aviva. She, her, cisgender, female. So I saw my mom and dad, not myself and my partner. So I guess I'm in the minority there. But what I thought of when I saw, you know, trans masculine, trans feminine people in my mind, you know, I saw two of my friends, but what really sticks with me is that it's still very binary. And then I'm not seeing anyone in my mind who is non-binary, gender diverse, and so we're still stuck in this binary when you're asking us to see these people, and so we're not really having room for anybody else.
Where are the people in the middle? People's brains, maybe your brain, people's brains tend to go to that binary about what it can look like.
Oh no, I'm saying kind of I feel like the opposite. I'm saying I don't have. There are many more people who don't fit in when you say, you know, okay, now imagine a trans woman and a trans man, but I don't have anywhere to put everyone I know who's identifying as non-binary or gender non-conforming or genderqueer, because they don't fit in, because even being trans, a lot of people I know identify within a binary, right? Because they might just be going to. So I think that in itself isn't giving us much room.
Yeah, the available images. Thank you very much. Thank you. And the question that I have is, and what we're going to be thinking about is, how do we imagine these biases that we have affect our clinical judgment with our patients, affect how we see people, affect the questions that we ask to people? That's just a rhetorical question. I don't have to answer. We'll be working through that together. I'm interested, again, maybe you can think about this. What did you notice about the images that came to mind? What biases came up? What can you do when you become aware of these biases affecting your judgment, your clinical judgment, how you see people, the things that you ask, the ways that you see gender? If you're neglecting to think about the range of trans people in the world, again, like we were thinking about in terms of non-binary people, what effect do you think that has on each client who comes to work with you? These are the questions. These are the things that people are asking to themselves to understand the impact that their gender and their gendered experience has on their work with their clients. And all these experiences, these biases influence how we feel towards our clients, and the working alliance that we build with our clients. I'm going to move on to talking a little bit about the working alliance. And again, I'm a therapist, so I'm a little so the way that I talk about this might be a little biased in terms of psychotherapy, but the working alliance, the relationship that you have with your patients, is not dependent on the career that you have or the title that you have. We all have working alliances. And the quality of the working alliance or the relationship that we have with our patients impacts the quality of the services, the quality that they are delivered. If you don't have a good working alliance with a patient, they're not going to do or follow or suggest what you're looking for, the ideas that you have about what's going to be aligned with their health. There's this idea of being a blank slate. I'm an expert. I'm a doctor. I do these. I have these skills. Who I am doesn't quite come into the room, but you cannot ever be absent of your history, your culture, your expertise, your biases, whether they're conscious or unconscious. All of that comes into the room and has an impact on how you see your patients or what happens when you work with your patients. These experiences influence the questions that we ask, whether we do ask something too much or whether we omit something. We want to be thoughtful and careful about how our own stuff, what we bring, impacts the working alliance in the relationships that we have with our patients. So research suggests that there are at least three different areas that are implicated or significant to contributing to creating a good working alliance: emotional bond, trust and caring and respect that you create with someone. And then the agreement upon the goals, and collaboration on the work to be done in treatment. The work to be done in treatment is based on, evidence-informed treatment, feedback from the client, feedback from the clinician, and aligning and joining with the client for the purpose of the work that you're doing is important. The strength of the working alliance that you build with the client is can be based on the degree to which you agree to the goals that you're working through and the quality of the bond that you do have with the person. And this is essential for if your interventions or if the change that you're trying to make with the client is going to be effective or not. And then we'll talk kind of like specifically about a good working alliance for a trans and gender diverse person. So our gender journeys that we have, the inner experiences that we can activate, that can really activate experiences that we've had around gender, around working with, especially when working with gender diverse clients. And we must be aware of the impact that our bias has on these individuals when we get activated. So again, I want to do another little activity here, an exercise. So whatever the piece of paper you were using, flip it over or open up a new document, find a new section. So I'm going to ask you to look at these questions here. So what is your gender? How old were you when you figured this out? How do you know this is your gender? What makes this clear? And I want you to try to answer these questions without referring to body parts. Go ahead and try to answer these questions, talk about your perspective, and then we can, then maybe I'll ask somebody, the volunteer, to talk about the responses. If anybody has a response, feel free to share.
I never went out to a child without my mother saying, "Remember to be a lady."
We're told this is what a lady does. This is what a lady is supposed to be like.
When I would say I recognized my gender when I was taught.
Yeah.
And I think that was like somewhere around maybe like 5th grade, 4th or 5th grade. I was taught that what my gender was, and similar to the person that just spoke, my mother would say things like, remember, you're a girl, you have to keep yourself neat. You're a girl, you have to do X, Y, and Z. But also kind of coincided with, and I don't know how to explain this well, but it kind of coincided with me starting to like people of the opposite gender. So it kind of solidified that I was this gender. And I know that doesn't make sense in the terms that we are using now, but that was when I had more of a understanding.
Sure. When you get a little bit older, I think there are more rules about gender, how you can be, expectations about how you're supposed to be in relationship to another person. And I think it really, what you're saying really makes sense with gender training, how we're trained from children to think about gender. Absolutely. Thank you for sharing. I think I saw another hand.
That's me.
Jump in.
So I actually just recently had a conversation with my mom just about like my own childhood, and I think I kind of just always knew that I was cisgender female before I really even understood what gender was. I would pick out my clothes. There were standard girl clothes from the girls section. I always had like my jewelry, my handbag, from a very young age, necklaces, everything. And I had just a very strong personality from a very young age, and I just kind of always knew like what I liked. I wanted to play with Barbies, a lot of things that are stereotypically for girl children. So it's one of those things I kind of just always knew my whole life.
There was something euphoric, exciting about being a woman and, picking out the toys.
Yeah. I loved my Barbies. I loved my jewelry. Like would have them up to my elbows when I was like 3 years old.
Yeah.
My little purse, all of it.
I guess I appreciate this example because, I think for most, I don't know, for most, a lot of cisgender people have that experience of, it feels good to fulfill this role, to do these things. It's consistent with who I am, and people like it, that I'm feminine and like that sort of thing. But I'm curious if anybody has, maybe I'll speak to my experience around gender. I wonder if anybody else had a diversion experience from that. I think I remember when I think about this, what comes to mind for me was wearing socks. I could never, apparently there was a rule that boys don't wear long, high socks. That was not in my family. That was not a thing to do. And I was like, what does this even mean? It was like a feminine thing, I guess. And like, I just remember I was kind of like a pinned up sort of kid. So I thought it would look really nice with the rest of the outfit. But I remember being kind of like scolded for that, or I felt excluded because I wasn't doing things that were in alignment with the gender expectation of being a boy early on. And I remember confusion about it. Like, what are you saying? What do you mean? We were speaking to intersectionality before. I'm a gay man, and that experience of being penalized for not adhering to gender norms was frightening. As someone who could get like found out something's wrong with you, the way that you do gender, is the message that I had. I see Samantha. I think I can see. Go ahead. Go ahead and jump in if you have a response. All right. Any other?
So for me, I had an interesting experience because my parents. I mean, yes, they dressed me as a girl and they referred to me as a girl when I was a little kid, but they also encouraged me to dress in other things or to play with different things than Barbie. So I had a set of Barbie dolls and things of that nature, but I also had Tonka trucks and Hot Wheels and all of those kinds of things. I grew up as an only child, but I grew up with boys and girls who were sort of like siblings to me, and a lot more boys than girls. And I didn't realize until like not that many years ago, like somebody told me, you kind of walk like a dude. And I'm like, I kind of do. And then I thought back that I actually changed the way I walk a little bit because I like a certain style of clothes. Like I like the whole like work boots with the slouchy jeans that guys would wear. And in high school, like I had at one point, one day I'm wearing my cheerleading outfit to school and I'm doing that, which is very female with the little skirt and everything. But the next day I'm wearing my black jeans, my Converse high tops, and my Anthrax t-shirt to the point where I'm standing in Spencer's Gifts looking at a concert poster, and somebody came up behind me and said, "Hey, dude." And I turned around and I said, "Oh, you're a girl." So there were some of these experiences that I had, but I never really realized any of it because they just seemed natural to kind of flow back and forth. So there's some tomboyish elements of me. There's elements that are really girlish of me with my nails. If anybody knows me, you know about my nails. But, you know, I like to do things that might be considered gender specific in both ways, girl things and guy things. Like really guy things, like to the point where somebody thought I was a guy.
And it sounds like from your experience, it wasn't very, you know, challenging for someone to say that to you. It felt like your environment was open, you were allowed to really explore your gender.
Yeah, that was very affirming. And I didn't take offense. They thought that I would, but it's like, well, I like this style of dress. And if I'm dressed sort of like what people think a guy would dress like, then I'm okay with that because that was the look. Like, I don't know, you know, it didn't bother me at all. In fact, I actually like having some more masculine sorts of things. Like I like to mow the lawn, and my father taught me how to do cement work and stuff like that. I like to do that. And I do it with my nails. So it is what it is. But it's just something that was my experience. But it was definitely something that my parents had no issue with. I mean, I could wear whatever I want, act whatever way I want, and hang out with boys and girls. It was kind of very affirming that way.
And I appreciate that perspective, especially because it points to, depending on how you grow up, the parents that you grow up with, particularly the authority, the environment that you grow up in, really has an impact on your relationship with your gender, how much you feel like you can express it. I spoke to, and I guess I'm curious if other people had this experience too, where their gender was policed. You know, the thought that like you have to express yourself in a certain way. Other ways of expressing yourself are not appropriate. This is what transgender and gender diverse folks experience, depending on the families that they're in, the cultures that they're in, the time that they're in. And so, you know, thinking about what it might be like to have your gender questioned, reprimanded, this part of you that you engage in every single day. There's no respite from the boys' clothes, the boys' shoes, the girls' shoes, the images that you receive on television that reinforce how you should look. This word here, gender policing, again, is the idea that some influential person in your life determines or tells you how you have to express your gender. Sometimes this can be a hard exercise, particularly for cisgender people, which I really appreciate the individuals who did speak up, because sometimes people struggle with this because they have not been asked about their gender, asked to think about it, asked about sort of like the privileges that they experience when, because their gender identities were congruent with the sex that was assigned to them at birth. Sometimes it can be hard because people think they know about what their gender is, but they haven't really taken the time to really think about it, where it comes from, who contributed to it, the messages that they received. Period. So all of that, those social contributions, they have an impact on us, and they sit with us, either implicitly contributing to implicit bias, but in a more explicit way. So, you know, implicit biases are the biases that occur outside of our conscious awareness. They can be positive and they can be negative. Additionally, so can explicit bias. It can be positive, it can be negative, but those are things that are in our awareness. and the biases that we have, the rules about gender, about gender expression, those can come out in our relationships with our patients. And again, the important thing to think about here is, how do we recognize and manage those biases, those expectations around, you know, what someone's gender should be, how they should pass, what they should look like, how they should adhere to the gender binary if they do. You know, I like to break it down into these 3 areas here. Self-awareness, this is what happens before the session, the appointment that you have with someone, the encounter that you have with a patient. Who am I? What's going on with me? What are my, or what, where do my biases come from? Self-exploration, when you're with a patient and emotional reactions come up, where do you go? What do you do with them? And then self-care. This is a way, again, to recognize, to manage some of the biases that that come up for us, because there can be intense emotional reactions around gender, whether that is positive or negative for people. Again, so for self-awareness, questions that you might be asking yourself is, how do people tend to respond to me? How do you believe you are perceived? When a client comes up to you, do you tend to be perceived as a cis person? Can you pass as not trans? Are you perceived as masculine, feminine, inviting, comforting, warm? Thinking about those things and how they might impact the relationship that you have with your patients. You know, how are you doing today? What's going on for you right now? Are you experiencing stress that might contribute to the relationship with your clients? How might your life, what are things that are similar that you experience with the patient, and what are things different that you experience with the patient? If you do have differing gender expressions, how does that impact your patient, the feelings of safety that they have, the feelings of comfort that they have, and if you're experiencing someone who has a similar gender identity than you have, how does the similarity inform how you think about that person, about their expectations around gender, about how well they conform to thoughts about how people should express their gender. Yes, being aware of the qualities about yourself that others may see and may not see. Again, your spirituality is something that someone might not see if it's not on you, if you've ever been in treatment, what your politics are, what your relationship history are. All of those experiences inform how you're going to respond to somebody, and you should keep in your awareness. Now, in terms of self-examination, when you're in the moment with the client, investigating your own experiences, your interactions with the client. Is this when you're feeling anger or frustration? Is this something that I'm bringing into this relationship, or is this something that I'm feeling from the client? Good things to be aware of. Do you have any feelings? Most of the times when you see certain clients, when I see trans clients, someone mentioned maybe having a feeling of protection, or a fear of like messing up their pronouns, or these are important things to understand and to not let impact, to bring into your conscious awareness so that they're not unconsciously impacting the work that you have with your client. Let's see. I skipped this one, excuse me. Again, questions to ask when you are thinking about your self-examination. How do you discern your own reactions? The thoughts that you're having in the moment, the emotions, the images that come to mind, the physical experiences that you're having, those are important to pay attention to and to make meaning of. What do you do with your own reactions? Where do you put them when there is someone says something, it upsets you? We were talking before about someone using fraudulent pronouns. what do you do with the anger that comes up for you, and where do you put that in the service of the works that you're doing with your clients? And finally here, when we're thinking about self-care, what do you do with your reactions? How do you manage the guilt, the shame, the feelings that come up for people, for you? I think a good way to do this in a professional way is to consult with your colleagues and supervision, reading and taking continuing education courses here, asking questions, perhaps your own therapy, if that is something that you're looking to do, or you want to support your own self-exploration. You know, personally, again, you can talk to your colleagues, talk to your friends, journaling, writing through your feelings, really attending to this wellness wheel here. How am I doing spiritually, socially, environmentally, emotionally, physically, intellectually, spiritually, really attending to all those areas of your life and developing a plan to really take care of yourself, so those reactions that you have to the clients that are in front of you that are influenced by your implicit or your explicit biases don't come out in the relationship.
Christian, the slide I'm seeing on my screen still is on the definition of cultural competence and humility.
Oh, are you serious? Oh, I'm so sorry.
No, it's okay.
I don't know how to change that.
There we go. It's moving now. It's on working alliance summary, self-care. Okay.
Okay. Working alliance summary. Okay. I hope people were able to see what I was talking about before, but again, it's a good idea to keep an eye on the working alliance, our experiences that impact because the experiences that we have impact our emotional bonds and the trust and the caring and the care and the respect that are developed in the relationship with our transgender and gender diverse clients. We need to be aware of our gender narratives and the intersections that influence our biases and impact our reaction with clients. We also need to be aware of our clinical perceptions of us and the potential biases that impact our work and our relationships. And again, recognizing and managing our biases it requires heightened awareness of unpacking our own experiences, continued education, and ongoing self-care. Okay, so that is the end of our thought about our awareness and how that impacts the clinical relationship. What I have for the rest of this presentation is just some resources that might be helpful in terms of your training and your building your clinical understanding of working with trans and gender diverse individuals. I want to highlight two of these here that I use often in my training and my education, which would be the National LGBTQ Health Education Center. This program comes out of the Fenway Institute in Boston, and they have a wide range of training resources, online modules, publications, video trainings, that if you are trying to build your competence in working with LGBT individuals, you can go here. They give out CE credits. A lot of the stuff, a lot of the program that they do is free. And it's really top-notch quality programming. The World Professional Association for Transgender Health, as I referenced before, they come out with standards of care for medical treatment, psychological treatment, legal recommendations, working with children, working with adults. Recently came out with new standards of care. So again, if you're looking for what the recommendations are, evidence-based recommendations are for working with trans and gender diverse individuals, that is an excellent resource. So these are books that I particularly enjoy and reference often. A Clinician's Guide to Gender Affirming Care. A lot of the training references that I use today came from this this text, and there was a recent version that came out in 2021. Again, excellent framework for gender affirming care for medical providers, mental health providers, people that are looking to build their knowledge. This would be a good place to start. Trans Bodies, Trans Selves is an excellent book as well. It's like a library of the trans experience. Talks about culture and race and advocacy and surgeries and mental health. It really is just like a culture guide, really, for working with trans and gender diverse individuals. Trans Sex is an excellent book as well for any mental health clinicians looking to understand how to work with individuals who are having issues with sex, who want to build their experiences with sex. So there are not many texts out there that specifically address this area, this really important area of working with trans individuals. And then, as I mentioned before, there's a preponderance of autistic individuals in the trans and gender diverse community, and there are some texts out there. This is Supporting Transgender Autistic Youth and Adults was an excellent book that I found very helpful in my work. And then again here, if you're looking to support your patients with legal resources, the Human Rights Campaign, Transgender Law Center, the National Center of Transgender Equality, are very good resources to point your patients in the right direction. And here are just some supportive resources for patients and their families, P5, the Trevor Project, and Family Acceptance Project. So that's all I have for today. Left a little bit of time for questions. So I'm curious if people have any questions for me.
Thank you, Dr.
Yeah, I have questions.
Oh, okay.
Oh, thank you. Go ahead.
So thank you, Dr. Credo, for the presentation. Thank you so much. So quick question, right? If you have a patient that sex at birth is a male, he is in the process of switching over to a female, but it's not completed. The process is not completed yet. So how is it best room assignment for the patient in question? Is it better to house him with male, or is it better to house him with female? It's a male, sex assigned at birth is a male, but identified as a female.
So you're saying you're working with
not complete the surgery yet.
So you're saying you're working with a trans woman, was someone assigned male at birth, and your question is, what would be the best housing for them, or the best unit? Is that what you're asking?
Yes, like in a hospital where we are now, we basically co-ed. So what would be the best? Would you give room on the male side or room on the female side for this individual?
Now, I can't quite answer that question, but I could tell you, what I'm going to tell you is what I would consider, how I would consider making that decision with the patient. Again, I think what their desire is, I guess what her desire is, where she would feel the most safe. How long she's going to be in the hospital. If this social transition is something that she wants to do in her time, in her treatment while she's here. That decision I would make in collaboration with the treatment team in the impacts and the thoughts and the suggestions that they have. Additionally, any mental health conditions that they have, their level of the risk that presents itself, depending on who you're working with, Those are all things that I would consider. So I would definitely need more information to be able to make a determination of who would, or how we would go about housing someone. But again, I think it's the integrated team would be really essential in making that decision.
Okay, thank you.
But I guess I will put and draw your attention to the World Professional Association for Transgender Health. Again, they would say that housing someone in housing that's congruent with their gender identity would be the most affirming of their gender. But again, I think what the patient desires kind of makes the choice in alignment with self-determination. So I think those are the things that I would consider. Any other questions?
Hello. My name is Ojo. I just want to appreciate the concept of the training. And from what I learned, I think you said cultural humility is a lifelong process. And I'm trying to compare the cultural humility with cultural competency. Can we all agree that cultural competency is an end product of what we learn from the cultural humility? Because when you look at the competency, it has to do with your belief and values, right? So can we say the competency is an end product of cultural humility? Thank you.
You know, actually, I think I agree. They definitely have a relationship. It is necessary for you to know about someone's culture, their experience, their how they grew up, what their beliefs are. That's essential for you to be able to competently work with somebody. I think what cultural humility does is it adds that element of the self-reflection, who you are and how you impact the patient in their relationship. That's what that adds. So yeah, they're definitely both important. One's maybe not important than the other, but they're both essential.
I would have heard it as one is about learning as much as you can, and the other is about assuming you don't know it all yet.
Perfect. Excellent. That's right. All right, any other questions? Okay, well, I just wanted to thank everybody for being here and actively participating in this discussion. I will certainly send my slides or any links that I have to Dr. Waldron to disseminate to whoever is interested in learning more. Yeah, I appreciate your time and allowing me to speak today.
Well, we appreciate you being here. Thank you, as always, for a really enlightening presentation. Dr. Christian also does a colloquia presentation, a full day for the interns. And so that's why we invited him to do this training for us today. So I wish your camera was working because I would love everybody to see who you are. But I am sure we will have you back for more CMEs and, of course, for colloquia. But thank you so much for everything. We really appreciate you. And thank you, everybody, for being here, for participating. And I hope you all have a great weekend.
Thank you.
Thank you, Dr. Credo.
Survey is now open. The link is in your slides and in the email. If you cut and paste it into Chrome, oh, I see somebody just gave their first response. If you paste it into Chrome, that works best. Sometimes Edge is a little wonky with the Survey Monkey, so that's what I would recommend. If you have any issues or anything with the survey, please let me know. Once I get the slides and things like that, I will send it to you. If you wanted links to the videos,
just send me an email letting me know. I realize that there's a lot of people on the distribution list who aren't here, so it might seem odd to receive a link to a video without any context. So please just email me if you would like the slide. I mean, the link to the video. All right.
Hey, Nicole, this is Dan from the STU. If you want, just send me that information and I'll send it out to our staff instead of the 100+ emailing you.
That would be wonderful. Thank you.
That'll save you one big step. So nobody email Nicole from STU. I'll send it out to you guys once I get it from her.
Sounds good. Thanks. All right.
Nicole,
everybody.
Quick question, Nicole. The Survey Monkey is also on the poster, I think, right?
The Survey Monkey is on the flyer. Yep. If you just cut and paste that link that's right in the middle of the flyer, you'll get right to the survey.
Right. Thank you, guys. We need more of this. This is very helpful to our practice as well as to our personal and professional lives.
Thank you. Absolutely. I agree. Yeah. All right. Bye, everybody.
Yep.
Thank you. Thanks for the presentation.
Thank you. Bye. Excellent presentation.
Thank you.